Well, thank you, Dr. Pallade, for your kind introduction. It's an honor and privilege to be here to talk to you. The last time I was here at this podium was when I gave my graduating resident grand round a few years back. And it's really, it's a very good moment for me today to come back to meet you all and talk about this topic. So we'll try to keep it as interactive as possible. There will be a lot of data, which I will kind of try to move through fast, just in the interest of time. However, you can stop me to ask questions if there is something you would like to know more about. Okay. So the topic today will be patent foramen ovale closure and left atrial appendage closure, the difficult questions. My disclosures. I have received an education research grant from the American Board of Psychiatry and Neurology. It's an education research grant, nothing to do with today's topic. I do not perform any of the procedures mentioned in this talk, and I do not have any industry affiliations with manufacturers of closure devices. I direct a popular 1-hour course by the same name at American Academy of Neurology annual conference every year. I host a panel of invited speakers, such as Dr. Shadi Adi, Dr. Larry Goldstein, Andrew Leventhal, many of them are famous names in the stroke world, parts of whose content I may use during today's talk. So why talk about this topic? So let's start here. In 1996, there is a coveted Willis lecture, which happens at the International Stroke Conference every year. This was delivered by Dr. Jesse Thompson, who is a vascular surgeon at Baylor. And if you look at the content of the talk, it was at length about the carotid. Since then, until now, we have developed new surgical methods for stroke prevention. And some of these, the two of which we will discuss today. Second, this is a personal important perspective that I would like to highlight. So when I was a faculty at University of Kentucky, or even now, we do a lot of lectures on evidence-based stroke practice. Once you learn the evidence, it is easy to become arrogant and say that, hey, we are invoking this clinical trial for decision making. However, it is very important to learn that the evidence that we know, it can flip on its head in a few years. And this is not something which is historic. This was when I was a resident in 2018, that there were 3 new clinical trials which were published in the New England Journal of Medicine, and which was accompanied by this editorial called The Tipping Point for Patent Foramen Ovale Closure. Before 2017, the American Academy of Neurology advisory said we should not close PFO for cryptogenic strokes. But after that, we now close the PFO. So it sort of highlights the importance of intellectual humility when we learn about evidence. Also, as you know, this Oxford Pyramid of Evidence, the systematic reviews and meta-analysis are on top of the pyramid, and case reports are at the lower level. So evidence is just one part of evidence-based practice. It is very important to sort of integrate with patient preferences and individual clinical expertise to make nuanced decisions. And especially in areas where there is not sufficient evidence, we should be able to bring together all these 3 to make the best decision for our patients. And how we use the evidence defines us as clinicians. So the topic that we are talking about today, say for example, the left atrial appendage closure, which is a treatment for atrial fibrillation, it has high impact. The risk of the AFib incidence is rising, and by 2050, there will be almost 8 million people who will have AFib in the US. And the risk of AFib increases with age. We know that warfarin is almost 60 years old and is still causing problems. And 25% of patients who we start on a DOAC do not continue to be on it at the end of the first year because of several reasons listed there. So therefore, I find this an innovative method of treatment which thinks out of the box. Site-specific treatment or a mechanical occlusion of left atrial appendage for left atrial appendage occlusion, in a way, it sort of appeals to me as it is an innovative procedure. Why? Because 90% of clots in non-valvular AFib is formed in the left atrial appendage. A chicken wing shape of a left atrial appendage is the most commonly seen shape, and a cauliflower-shaped appendage has the highest embolic potential. Also because initially when this procedure, so the Watchman device has been in market since 2002. And then over the time period in the several years when FDA approved it, you would see initially there were a lot of controversies because of high procedural complications. Over time, this has improved. So given these controversies did exist for so many years, therefore, it is also a topic of interest to talk about. So there is this in cognitive psychology, the concept of Maslow's hammer. I suppose it is tempting if the tool that you have is a hammer to treat everything as if it was a nail. If you find a PFO and in the community, the patient may just get a PFO closure regardless whether it will be beneficial for the patient or not. However, these are new tools in a stroke neurologist's armamentarium, and the outcomes will depend on knowing the right place to use these. This is one of my favorite Hippocratic aphorisms. Life is short, art long, opportunity is fleeting, experience is delusional, and judgment is difficult. We will try to look at the evidence that we have on these procedures and see how to best use these for our patients in a few cases at the end. So PFO closure. What is the incidence of PFO? So these are very old autopsy studies from 1980s. And if you can see, roughly around 25% of people have a PFO. So these were not patients who had stroke. It's a normal population. So 25% of normal population have a PFO. And you can see in the younger age group, the incidence is higher and it falls as we grow older. Well, the PFO does not close as we grow older, except it is more commonly seen in younger population. So 25% of general population have a PFO, like I said, and 37% of those with cryptogenic stroke have a PFO. What is cryptogenic stroke? PFO may be causal. A cryptogenic stroke is a non-lacunar stroke, which is not attributable to cardioembolic or atherosclerotic factors. So that is a definition of negation, and therefore it is very tricky. A new definition, a new concept of embolic stroke of undetermined source, ESUS, was introduced in 2014 in Lancet, Hart et al. So 25% of all ischemic strokes, as you see here, are cryptogenic. 33% of those meet the ESUS criteria. And 21% of patients with ESUS have a PFO. Therefore, if you do the maths, 1.7% of ischemic strokes patients have ESUS, and they also have a PFO. So that's a very small percentage. So like I said, 25% of normal population have PFO. However, only 1.7% of ESUS patients have PFO. So therefore, there was this big study in 2013, which put together more than 3,000 cryptogenic stroke patients and put 12 different databases to find what are the risk factors which are associated with causal risk of stroke in patients with PFO. If the patient is a smoker, if the patient has diabetes, if there was a deep infarct on the MRI scan, if the patient has hypertension, if the patient is older, and if the patient has a history of stroke or TIA, it's more likely that the stroke is related to those causes than related to PFO. So you can see from the regression equation, a sort of rubric is proposed here, and each risk factor gets a certain point. So the higher your ROPE score, the more likely that the stroke is related to your, yes, the higher your ROPE score, it's more likely that the stroke is related to your PFO. So PFO attributable stroke risk, you can see here, the blue boxes is the 2-year recurrence risk of stroke, and the white boxes are PFO attributable fraction. So 7 or higher ROPE score will be considered as high ROPE score. In patients with high ROPE score, the PFO attributable fraction is very high. It is 70% to 90%. However, patients with low ROPE score, the PFO attributable fraction is low. So this is very beautifully written in the American Academy of Neurology's advisory. The risk of stroke recurrence in patients with PFO and no other etiology is low, approximately 1%, like I was saying in the previous slides, per year among individuals treated with medication alone. This stroke risk is generally lower than that caused by possible common stroke mechanisms. Thus, if an alternative plausible higher risk mechanism of stroke is identified, it is likely that PFO was an innocent bystander, and you cannot attribute the causal risk to PFO if the patient has a pile of other risk factors that we noted in the previous slides. So what we just talked about are what risk factors the patient has, okay? But we did not talk about the characteristics of a PFO. Say, for example, in the first image, the patient has a straddling thrombus that was seen on the echocardiogram in the PFO. Or, for example, the PFO was large. So what is a large PFO? If you have, so different studies have different definition criteria, but if it is 20 or more bubbles seen, in the bubble study, then the PFO is considered to be a large PFO. If there was an atrial septal aneurysm, a dilation of the atrial septum, which would become the nidus for new clots, then the PFO attributable risk increases. If the patient has a concomitant DVT or pulmonary embolism, then the hypothesis of paradoxical embolism will be more probable. So these factors were not taken into consideration in the ROPE score. And therefore, a new rubric was recently proposed in 2020 in JAMA Neurology. This is called the Pascal. So Pascal is a PFO attributable risk causal classification. If you can see, on the right side, it takes into account ROPE score. ROPE score greater than 7 will be considered high. And on the left side, it takes into account the characteristics of the PFO. So for example, if a PFO had a straddling thrombus in it, even if the patient had low ROPE score, it is definite, the Pascal classification, the causal risk of the PFO is almost definite, okay? So this sort of rubric is proposed. Similarly, large PFOs and presence of atrial septal aneurysm will attribute more causal risk. So if the PFO, the classification, the Pascal classification is possible or probable, then the benefit of PFO closure is high. So it will reduce the absolute risk of recurrent strokes by 2 times. So one thing to remember here, one important adverse effect of PFO closure is AFib. So it can increase the risk of AFib 4 times. And we know that the risk of AFib increases as we grow old. So if you close a PFO in an older patient, it's more likely that they will develop AFib and it may not be as helpful, okay? As you can see in this chart on the right side, if the Pascal classification is unlikely, the risk of AFib detection is 4.5% after PFO closure. But if the Pascal classification is possible or probable, the risk of AFib detection is lower. Okay. So there are 6 clinical trials, or 7, of PFO closure. This is a very populated slide. I won't go into this. But in general, you can see the inclusion criteria for most patients who were included in this PFO closure. They were below 65 years of age. Okay. So therefore, if your patient is above 65 years of age, it might not be worthwhile to look for a PFO. You would not use the evidence for patients because they were not included in the clinical trial. The second point here, if you can see the initial clinical trials that were there in 2012 and 2013, these clinical trials included patients with TIAs. And so TIAs, these patients do not have MRI-proven strokes. So the question is, possibly, therefore, these clinical trials were initially negative. And then they started becoming positive as you included definite strokes that were MRI proven. Okay, so if you put all these PFO closure trials, they had different outcomes, endpoints, and there is a lot of heterogeneity. But having said that, you can still see that PFO closure is beneficial in patients over antiplatelet therapy and antithrombotic therapy, especially in ones with higher ROPE score and a favorable, attributable risk on Pascal. Okay, so antithrombotics in patients with PFO. In patients with PFO, you can use an antiplatelet or an anticoagulation. Say, for example, if you don't do a closure. So which one is better? So this is a study in stroke in 2021. And you can see that the point estimate favors anticoagulation. However, the composite sort of results, they cross the unity, and therefore you cannot say that anticoagulation is in fact useful compared to antiplatelet in these patients with definite surety. So what is the sensitivity of PFO diagnostic testing? So there are these small studies which compare a transthoracic echocardiogram with transesophageal echocardiogram, transcranial Doppler. If you see the transesophageal echocardiogram and transcranial Doppler, they have very high sensitivity, and transthoracic echo has low. In our hospital, if I remember at UFL from my residency days, most patients get a transesophageal echo. This is not true in the community because a transesophageal echo can be invasive. And if you do not have high volumes at your center, it might not be a safe procedure to do in all patients. Okay, so this is an interesting study from stroke recently. There were 450 patients who got they all are stroke patients. They got both a transthoracic echo and transesophageal echo. If you can see, the PFO detection was almost double with transesophageal echo. And the one other finding which transesophageal echo was better at is vegetations. So if you are suspecting vegetations or PFO in a patient, a transesophageal echo might be a superior choice compared to transthoracic echo. So the American Heart Association does say that transesophageal echo, transthoracic echo, cardiac CT, and cardiac MRI might be, methods for diagnostic testing in patients with PFO. This is the European position paper. As I say, transcranial Doppler has pretty good sensitivity comparable to transesophageal echo. So therefore, it might be a second step after transthoracic echo. This is a very good algorithm which was proposed recently in the Stroke Journal to summarize everything that we know. So you first perform a transthoracic echo. If it is negative, you try to confirm with a transcranial Doppler with bubble. If that is positive, you can do a transesophageal echo, and if the Pascal classification provides an attributable risk to the PFO, then you close the PFO. Let's use it for a patient. Okay. So Miss B is a 37-year-old right-handed woman with history of migraine headaches, ADHD. She is on amphetamines, polycystic ovarian disease on hormone replacement in past, but currently uses estrogen contraception. She recently experienced an episode of transient right-handed weakness that lasted a few minutes and resolved spontaneously. At that time, Miss B was in the OR. She works as a surgical tech, but she did not seek immediate medical attention. She later saw the primary care doctor after 2 weeks, who ordered an MRI scan, and the MRI brain showed a left posterior limb of internal capsule flare intensity, for which she was referred to stroke clinic. She does not smoke or use any illicit drugs. Her father had a stroke when he was old, but he also was a heavy smoker. Primary care physician ordered a CT angiogram of head and neck, as well as a transthoracic echo with bubble study, which were normal, without evidence of PFO. What is the most appropriate next step in the management of this patient? Focus on treatment of migraine with aura. Migraines can cause MRI changes. Initiate anticoagulation, as lab work for procoagulable state is slightly abnormal, if you can see in the box on the right. Obtain a transesophageal echo or transcranial Doppler to reevaluate for PFO, and discontinue dextromethamphetamine. The internal capsule lesion is a perforated stroke and possibly related to hypertension. So which of this will be your choice? How many people think it is A? You can just raise your hands. I did not design the poll. So how many people think it is B? How many people think it's C? How many people think it is D? Okay, perfect. So let's think through this. Will PFO assessment be consequential in this patient? What is the patient's ROPE score? The patient's ROPE score is 6. Is it low ROPE score or high ROPE score? It is a low ROPE score. 7 or high is high. Okay. So now, in this patient with low ROPE score, the classification, Pascal classification, will become definite, probable, or possible if the patient has a large shunt, if the patient has an atrial septal aneurysm or a straddling thrombus. Okay. The transthoracic echo, as we know, is not the best test to look for a PFO. And in this case, you do not have alternate explanation for why the patient would have a stroke. So we should look harder. Will PFO assessment be consequential? We already saw this slide in the past. And I told you that the risk of AFib increases by 5 times, 4 to 5 times after PFO closure. And this patient, however, is very young. So the risk of AFib at her age, a woman of less than 55 years of age, is very low. So the risk of AFib is very low. So we should look for PFO, okay? We already saw this slide. So Miss B had a TEE, which showed a large PFO. She was referred for PFO closure. She reports improvement in frequency of migraines since the closure. Patient was advised to avoid using estrogen-containing hormonal therapy. So what do we know about PFO and migraine? So there appears to be a dose-response relationship, which means if you have a higher size of a PFO, bigger PFO, and higher frequency of migraines with aura, then there might be some correlation. There is no strong evidence to suggest closure in these patients. However, there might be some relationship. Why is it so? Because the vasoactive compounds which cause migraine, they are usually metabolized in pulmonary circulation. So if you have a PFO, they can go into systemic circulation and possibly cause aura. Okay. We know that there are prothrombotic effects of estrogen, and PFO. So what do you do in patients who have PFO and concomitant thrombophilia? So we do a full thrombophilia workup. A clinician should counsel the patient that the efficacy of PFO closure in addition to anticoagulation cannot be confirmed or refuted. However, there are some small studies which say that if you have a PFO along with a concomitant thrombophilia, you might treat both, treat the PFO as well as treat the thrombophilia with anticoagulation. In these four curves, you can see if the PFO was closed and the patient was treated with anticoagulation, the event-free survival rates were higher. And which were the subgroups which benefit mostly? Patients who are older, greater than 60 years of age, and if the shunt size was large, and if the number of thrombophilia abnormalities were more than one, then those will be the patients in who doing anticoagulation along with PFO closure might be more useful. What does one do if the patient refuses to close the causal PFO? So you just do a thrombophilia workup, and then if there is a hypercoagulable state which can be anticoagulated, you anticoagulate or do aspirin. Go ahead.
So my question is that when you talked about the PFO plus thrombophilia treatment, what was the primary end outcome? Was it
recurrent strokes? Stroke recurrence. Yeah. Okay. So we have used the evidence that we heard of on this patient. Now let's use it on another patient. So patient C is a 66-year-old Caucasian male with past medical history of migraine headache with visual aura since 2010. Frequency on 3 to 4 times a year in cluster over 1 week. Hypertension, mixed hyperlipidemia, traumatic brain injury as a child during car accident. Presented to stroke clinic with new patient as a new patient for a possible TIA. He reports 3 to 4 episodes of sudden aphasia lasting for about 20 to 30 seconds each and resolving spontaneously. He denies headaches before or afterward. He denies other focal neurological symptoms or loss of consciousness. He denies involuntary movements like seizures. First episode was in October, was while he was reading a book. Suddenly the words did not make sense to him. 2 of those were in February of 2023 at 4 to 5 days interval. One of those was witnessed by wife as a brief 20 seconds episode of difficulty talking and frustration. She denied him having any focal weakness, focal facial droop or jerking or loss of consciousness. He's a retired engineer, quit smoking in 2010, social drinker, denied illicit drug use, no family history of stroke or seizures. As you can see, the MRI scan is normal. The transthoracic echo showed large PFO with 30 bubbles. Okay, so this patient is having some altered speech, episodes of altered speech, which last for a few seconds. The MRI is normal. Would you close PFO in this patient? Yes or no? How many people say yes? How many people say no? Okay, perfect. So yes, should we close PFO in TIAs? The answer, as we said, is no. The initial clinical trials, which included patients with TIA for PFO closure, were negative, and therefore it would not make sense. However, on the contrary, there's a very recent interesting patient I saw in clinic who has a clinical stroke with looks like a midbrain stroke with a eyelid droop while he was already on anticoagulation for certain other cause, and he's a very healthy young man. MRI is negative, but we think it's a clinical stroke, and it happened while he was on anticoagulation. We had a multidisciplinary discussion, and the patient was referred for PFO closure. So I would not close a PFO if the patient had a TIA, but if the patient had an MRI negative stroke, we may consider. So, okay. So as you know, migraine and ischemic strokes, they are in one continuum. That's an interesting paper in Neurology in 2023. You can read if you have time. So the equivocal causal risk for PFO, risks or benefits of closure were discussed with the patient, and a shared decision was made to not close the PFO a 30-day cardiac monitor was placed and migraine therapy was optimized for that patient. So you're aware. I agree with you. Okay, so let's switch gears now and talk about the second procedure that we'll talk. It's the left atrial appendage closure. So as we all saw this slide in the past, the risk of AFib, the incidence of AFib is increasing, and the risk increases with increasing age. So there are these new devices, okay? And basically, there are several clinical trials we can talk about, but the three big ones, the first one is called Protect AF and Prevail clinical trials. They used a device called Watchman device, which is a Boston Scientific device. And in these trials, these were compared with warfarin. And the PRAG 17 was a trial in Czech Republic, and this included two devices. One is called the Amulet device, the second one, and the first one is called, as you can see, is the Watchman device, and they were compared with a DOAC. The Amulet device, as you can see, has a ring around it, which can sit on the ostium of the left atrial appendage and might give better closure, is what the hypothesis is. But Watchman is the more popular device. Okay, so Protect AF trial included 707 patients. It was a non-inferiority trial. Patients included had a CHAD score of 1 or greater. So many patients with 1 or greater CHAD score would not even need anticoagulation. But in this trial, one arm was anticoagulation. And in those days, only 88% of the Watchmans were successfully placed. The non-inferiority was reached, but you can see in 5% of the patients, which is 1 in 20, you had a severe pericardial effusion requiring a drain, and then procedure-related ischemic stroke. You were trying to do this, procedure to prevent a stroke, but you could cause a stroke. So because of these complications, FDA did not approve the Watchman device at the time. And then Boston Scientific was asked to repeat the clinical trial, and Prevail is the subsequent clinical trial. As you can see in Prevail, the primary safety endpoints were better than the initial clinical trial. Similarly, in PRAG 17, which was a little better designed because it also included patients who have a higher Hasbled score. So these patients are patients who have higher risk of bleeding, and therefore, the left atrial appendage occlusion is sort of a superior choice. So when these three clinical trials were put together and a meta-analysis was done, you can see that the point estimate favors left atrial appendage closure in patients who have history of hemorrhagic strokes or who had hemorrhagic strokes. Right? So FDA therefore approved the LAA closure as a therapy in patients who have hemorrhagic stroke. Just to remind you, these were not the patients who were selected to be included in the study. Just based upon this analysis, this guidance was provided. So similarly, there are clinical trials about Amulet device as well. One thing is the Amulet device is associated with higher pericardial effusion rates and more device embolization rates. And there were worse outcomes with anticoagulation. And therefore, these patients were usually started on dual antiplatelet rather than anticoagulation. Not because, these devices endothelize quickly or anything, just because there was more bleeding with anticoagulation in this patient. So guidelines tell us what we should do. Clinical trials tell us what we could do. Registries tell us what we are in fact doing. So there's this large registry of about 66,000. By the way, by now, 250,000 patients across the world have gotten a Watchman device or left atrial appendage occlusion device. And we see that over the years, the safety endpoints have improved, and the composite safety is about 0.5%, which is pretty safe. There is this new device called the Watchman Flex device, which is a smoother device. As you can see, the anchors are sort of enfolded. So once you place the device, what do? The patients need 6 weeks of anticoagulation, 6 months followed by 6 months of dual antiplatelet, and just single antiplatelet thereafter. There are these newer studies, one of which was just recently published in JAMA Cardiology, which says that a lower dose of anticoagulation, like Eliquis 2.5 milligrams BID for the initial 3 months, might be sufficient and safer, in fact, compared to dual antiplatelet. Also, there is this paper which just got recently published a few weeks back, which generated some news. So left atrial appendage occlusion, in addition to anticoagulation, in patients who develop a stroke despite being on a DOAC. So this study, it's like a propensity-based analysis of a large database, and it's in 433 patients. And they showed that in patients who have a DOAC as well as a left atrial appendage closure, the risk of stroke was only 2.8%. However, if you only do DOAC, the risk of recurrent stroke was 9%, which is pretty high. Okay, let's do one question. Mr. A is a 67-year-old ambidextrous man who was recently admitted with a left M2 occlusion stroke, which was successfully recanalized with endovascular thrombectomy. MRI showed bilateral cortical strokes attributed to recent diagnosis of atrial fibrillation, not on anticoagulation due to cost. Patient's echocardiogram showed left ventricular ejection fraction of 55% and moderate left atrial enlargement. During hospitalization, pharmacy could arrange financial assistance, and he is currently using rivaroxaban as prescribed. After rehabilitative therapy, he has residual expressive aphasia, but no motor weakness. He used to work as a craftsman and is unable to use his chainsaw and chisel and other instruments because of being on anticoagulation. He shared a picture, for example, of the sort of craft work that he does. Which of the following is the next best management for this patient? Switch to warfarin to ensure long-term compliance. Refer to structural heart clinic for left atrial appendage closure. Continue on rivaroxaban. Left atrial appendage closure is not indicated because he has not failed and can tolerate anticoagulation. Refer for atrial fibrillation ablation to eliminate anticoagulation need. How many people agree with A, switch to warfarin to ensure long-term compliance? How many people say it is B, refer to structural heart clinic for LAA closure? Okay. How many people say continue on Xarelto, rivaroxaban, left atrial appendage closure is not indicated because he has not failed and can tolerate anticoagulation? Okay. And refer to atrial fibrillation ablation to eliminate anticoagulation need. Okay, that's very good. So before we even move to discuss this, I just want to clarify one thing, that the fourth point is absolutely wrong. There have been several studies and all the meta-analysis shows that if you do an atrial fibrillation ablation, then the risk of hospitalization with fatal arrhythmias reduces, but the risk of a stroke does not reduce. It is possibly because long-standing AFib can cause atrial cardiopathy, change in the architecture of the AFib, and there can be microemboli, and that is sufficient to cause strokes. Okay, so as we know, the American Heart Association guidelines says that we do it for non-valvular AFib. Left atrial appendage occlusion is done for non-valvular AFib who have contraindications to anticoagulation. And we already saw where that data comes from. However, in different sort of registries and different real world data, we see that the risk of stroke reduction in patients who have hemorrhagic risk is almost similar to those in patients who do not have a hemorrhagic risk. There are some newer studies which are currently enrolling to consider patients to compare Watchman with control in patients who are unsuitable for oral anticoagulation. So the inclusion criteria of unsuitability in those studies would be an intracranial hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, cerebral amyloid angiopathy, for example, uncontrolled seizures, which would increase fall risk, peptic ulcer disease, inflammatory bowel disease, lifestyle risk or occupational risk, like in this patient. So this is, and the patient here, for his quality of life, it was important, and he kept on requesting the left atrial appendage closure. And so therefore a shared decision was made in this case. He was referred to Structural Heart Connect for left atrial appendage closure for lifestyle or occupational bleeding risk, as well as non-compliance risk due to costs of anticoagulation. And the LAA was closed, and he is doing well thereafter. So to summarize, so PFO closure and LAA closure are two new tools in a vascular neurologist's armamentarium. Patient selection should be guided using criteria used in randomized clinical trials and causal risk attribution systems, some of which we just discussed. In patients not meeting randomized clinical criteria, but who demonstrate attributable risk for PFO and perceived benefit from LAA closure, real-world data regarding risks, benefits may be cautiously discussed during shared decision-making. For patients not opting for these procedures, a complete stroke etiology workup is essential to determine the antithrombotic of choice for secondary stroke prevention. So I would not take longer, and I would sort of summarize here. And I hope if I made a point to you that this evidence is not slam dunk all the time, and how to make nuanced decision when you have these patients in clinic, then I would have accomplished something. I will leave you with this interesting slide from BMJ. What are alternatives to evidence-based practice? Eminence-based practice, vehemence-based practice, eloquence-based practice, providence-based practice, diffidence-based practice, nervousness-based practice, and confidence-based practice. And you can see what are the markers and measuring device for each of them. So something for you to laugh at. So thank you. Nice talking to you all. And please, I will take some questions if you have any.
Thank you for the presentation. I just had a question about if there's any data regarding lower extremity valve that we keep getting whenever we have patients with PFO. I have never had a patient be positive, so I was just curious.
So if I go back to this, very good question. Thank you. So if you see this slide here, sorry, it's just flipping through very fast. Okay, here. So if you have a concomitant pulmonary embolism or deep vein thrombosis, okay, that sort of affects your Pascal classification. Got it? So it might be worthwhile to know. Many times, because if they have, then they will need an anticoagulation for certain reason, right? So, and then it might trigger more thrombophilia workup. So it might be worthwhile. Okay.
So, a couple of questions. So based on this Pascal classification, technically, if anybody who has high-risk features, right, PFO closure should be considered. Is that what you're saying?
So the Pascal is including both high risk as well as rope score. So it combines both. If the composite, so in that rubric, if the composite attributable risk is definite, probable, or highly probable, then they will benefit from closure. If it is possible or unlikely, then they are less likely to benefit.
So if they fall somewhere in a medium risk, for example, or possible and medium, so in those cases, I think it's better to just have that conversation.
Right.
And then let's try.
Right. And another interesting thing I see in clinics these days, that these patients, they were found to have a PFO and a cryptogenic stroke almost 10 years back, for example, because at that time PFO closure was not the practice. And now they come back with the stroke on the MRI and they say that, hey, I have a large PFO, how about close it? So that's another challenging situation. I don't know whether to close them. Like, for example, in carotid, if 6 months had passed since the stroke, you would consider that as an asymptomatic carotid. I'm not sure about the PFO. We don't have much evidence there.
The second question is that in your practice, how often do you obtain MRV of the pelvis, looking for major or something like that? Because routinely, we don't do that here. I just wonder, we used to do that a lot in Boston.
Yeah.
So I wonder if this is something that is done in other centers as well, or not too much attention.
Yeah, that's a good point, actually. At WashU, they don't do it so commonly, nor at University of Kentucky, where I worked earlier. But I acknowledge that at some centers, it's a common practice. She's asking just about lower extremity ultrasound, which is also not a common practice in many places. But I think it might be worthwhile if the suspicion is high. But I don't know what will be the factors which would put patient in that category, of high suspicion.
So
So
pretty young, and we can't find it for us. They usually do it, but we don't do that here. I'm not.
Right.
I'm not-
yeah, I haven't looked at literature. Might be worthwhile to see if we have enough papers or something to put together meta-analysis to just see what. That's a good thought, actually. We'll see.
How many balls does somebody have to be having regularly, and you can consider that contraindication for systemic?
How many falls? Well, that's a very good question. Oh, several falls. Actually, there is a website which can calculate how many falls you should have to sort of negate the benefit of anticoagulation by increasing the bleeding risk. It's like in hundreds.
I thought, so it seems like a lot of times there are patients who benefit from anticoagulation, who go out of anxiety, for that, patients fall 3 times.
Yeah. So the thing is this, like we said in evidence-based practice, if I go back to this slide, where is this? Yeah, patient preferences. If the patient is scared, like he doesn't want to be on anticoagulation, we can just tell them that, it needs so many falls, but bleedings are catastrophic and we don't want, if we can. So it's just a shared decision making. If you can convince your patient, do it. If you cannot, then don't do it.
I mean, worse with the providers. If there's a market stroke or cardiology, the doctors, the deal with names and they have.
Yeah, so in general, like just 2 or 3 falls is not a contraindication for anticoagulation for AFib. Okay, any more questions? Perfect. Thank you.
Maybe also.
Say.
In your practice, have you, for your patients with CAA, do you routinely just refer them with if they're having closure?
Yes.
Do you add
Yeah, antiplatelet, I do. And then there are, certain interventionists who would accept just a single antiplatelet for after a PFO closure. Like I showed that there is some mixed evidence, from smaller studies that single antiplatelet or low dose anticoagulation like Eliquis 2.5, those might be useful too. So if someone has CAA, then I mean, it would be a very good candidate for the LAA closure with one of these options, and can share the risks and benefits. We don't have very big sort of trials to sort of support this data as of yet. Actually, the reason I am responding, there are a few patients who we have done this and they did well, actually. Yeah. Okay, well, thank you. Are we near time? I think